Thanks for having me. All right, so my pitch is about the after-hours premium. And so policymakers decided to look at expanding access to primary care as a means of redirecting patients away from the ED. And does it work? Well, that depends on the healthcare system and the mechanism actually used to improve access. But Ontario has found success through the after-hours premium. Their incentive applies to physicians who provide services on weekends, evenings, and holidays. And they found that the introduction of the premium actually led to a reduction in less urgent ED visits. So then this study expands on that, exploring whether the latest increase in the premium in 2011 led to a reduction in ED visits, first within Ontario, and secondly, relative to 4 control provinces: Alberta, British Columbia, Nova Scotia, and Prince Edward Island. So then after controlling for a set of demographic, socioeconomic, and health-related characteristics, we found there was a reduction in less urgent ED visits within Ontario. But when we add in those control provinces, Ontario's after-hours premium was not associated with a reduction in less urgent ED visits. So this really shows that the effects of improved access to after-hours primary care are largely dependent on the context. So the introduction of the premium appeared effective in redirecting patients away from the ED, but the latest increase, not so much. So with that regard, Ontario serves as a bit of a warning to other provinces. So changes in the value of the premium may actually lead to significantly higher financial costs without any real benefit to the system. And so each province needs to look at evaluating their after-hours premiums prior to any changes. Thank you.
Okay, so it's Monica's turn to go first.
Hi, Michael. Thank you so much for your presentation. The question I have is related to the rural versus urban scenario as well, and where physician care in a rural setting may not be as accessible and having to travel into the ER for urban. Was there any look at how far people had to travel to receive care?
So for this study, because of the urban and rural differences, what we did was we first took everyone within a 10-kilometer distance of an ED, and then we actually excluded anyone living in a rural setting, just because oftentimes they use the emergency department for primary care services. And so because of that difference, the after-hours premium is not likely to apply to them. They're more likely to just use the ED for primary care compared to these urban residents.
All right, Hugh.
Thank you. I found your presentation very interesting, and being a father of 3 young kids, it seems like I'm always in the after hours. So one of the things I was thinking when I was reviewing your presentation over the last few days was, how does, there's certain regions in Canada where there's the labor market for primary care is very tight. It's hard getting a family doctor. Many people in a lot of the metropolis don't have any family doctor. And how does that impact with your your findings?
So we haven't really been able to look at so much the geography, just because already we've kind of strained it based on existing EDs that report to NACRs. And there's quite a bit of limitations in that.
I would just think that if you have a tight supply,
yeah,
even if you invest in a lot more primary, like after hours clinics and things like that, you still, the demand may still be there, and it could maybe impact that. But if the data is not available, then
yeah, for sure,
there's not much we can do, right?
Yeah, so one of the things is that after hours can only go so far. And with this policy, we kind of see that there's not that much of an effect with it. And so policymakers could definitely be looking at different ways of improving access, such as investing in perhaps a clinic beside their ED that can treat all those primary care patients, right, as well as just focusing on getting more primary care physicians into the system.
Thank you.
All right, Umit, you know the drill.
Yeah, very, very interesting. I think this whole, health services in Canada is one of the kind of wicked problems that haven't been, that's going to take a lot of attention many years to come. And I think if you're going to stay in this area, you'll be lucky, because these questions are not going to go away as far as I can tell. My question, I'm not even sure if it is really fair, but it also would have applied to all your other colleagues who have presented. Because somehow when I look at these and I look at the policy connection of the research, of the empirical work, I cannot help but ask myself, what if you were to utilize a mixed method, right? That you have a team, maybe you're not top notch in interviews, focus groups or whatnot, but you had a team and you wanted to enhance this, what you're doing with the quantitative methods, with some other types of methodologies on the same problem, on the same question, right? The premiums and effect and all that. Mm-hmm. What type of kind of additional, I guess, information or data, what type of information would you be looking for to bring better insight to what you're finding, so that your policy advice could be even further enhanced?
Yeah, so the actual goal of the after hours premium is to just enhance access to primary care. We're looking at a downstream effect that kind of offsets the cost. So while offsetting the cost is fine, it's good, but what we really want is to know, is this improving access? So if we were to do some qualitative research, it'd be good to bring in patients and see, are they actually getting improved access? Are physicians actually giving it to them? And it'd be good to bring in physicians to see, are people actually making use of their services, and how, and other ways we could improve. Because, for example, I don't think any clinic is really open at 2 a.m. I think they're all focusing on between like 5 p.m. and 8 p.m. And so it'd be nice to see like what patients are looking for in terms of after hours clinic availability.
Okay, Tammy.
Okay, so I was going to ask you the usual, quasi-experimental challenge type problems, but I decided to shift my question because what came to mind is, if I remember correctly, my doctor's office gets these premiums for having hours available in the evenings, but they also get penalties if I show up at an urgent care clinic. So I'm wondering about the symmetry of your results. We might not see much of an effect for those premiums in terms of where people go, but do you think the penalties might have a bigger effect?
Yes, so I think in Ontario, they have the access bonus. So physicians actually get that 28% top up. And then as you go to other clinics, it gets reduced. But the thing about that bonus is that it doesn't get reduced if you go to the ED. It only gets reduced if you go to a walk-in clinic. So that's why you find that physicians recommend you go to the ED so they don't lose money. And the other thing that they found was that from that access bonus, the physicians being rewarded are those where their patients don't use services. Those are the ones who are receiving the highest rewards from this. And so while that may play into part of our results, why we're seeing patients go back to their own physician, it's not that likely that it's going to affect ED visits, especially because physicians just aren't being penalized for their patients going to the ED. If we brought in results from walk-in clinics, we might see some interesting stuff, but nobody's really recorded that in a national scale for us.
Okay, and Claudia.
Great, thanks very much. I totally agree with Umit. After 20 years in health research, I see the same problems coming up. So you've got a long career. Thank you for your presentation. Great to see, I believe, sorry, the details are getting blurry, but I believe you used linked data on that one. So that was great to see. I do have a question that is somewhat data related, but I think it was raised in, so it's going to focus on your cross-provincial comparison. So these are inherently difficult in this country because we really do have, 10, 12 healthcare systems. We don't have one. And so the way in which care is organized and delivered could in fact explain some of these. But the question I have is more to the data as well. So NACRS is an interesting relatively new data set compared to DAD, for example. Our experience with it is we had seen some differences in terms of coding and the way in which provinces, actually within provinces, the way in which hospitals coded information in NACRS. And I wondered, which of course, as if that's where the main outcome is coming, is going to have an impact on your results. So I'm wondering if you could say something about the use of NACRS in particular related to your study, but more general about the use of it in cross-provincial comparisons.
So the biggest difficulty with it is that some provinces don't report at all. I think now they've gotten better, but back in 2009, I think there were maybe 5 provinces reporting. And while Ontario reports everything, you've got 4 provinces that only report a small proportion of their data. And so even the people living around these areas, they might be going to different EDs than you assign them to. And so we might only be capturing maybe 3 out of 5 ED visits. And so that coverage issue is definitely one of the biggest hurdles with using NACRS data. And so while it's improving, it's still going to be a challenge to use it. And so this study kind of gets over that hurdle by assigning them within a region. We're still probably underestimating ED visits for patients in, let's say, BC, Nova Scotia, where they don't have complete coverage. And then in terms of coding, we mostly looked at triage. Triage is going to be problematic because we're probably seeing different proportions of upcoding, for example. So we might be seeing more severe upcoding in other provinces, which it might explain that reduction in less urgent ED visits and might explain why there's really no change in urgent or very urgent visits, just because people are coding things as more severe in other provinces compared to Ontario. So it's definitely something that I wanted to look into later, and to actually compare like those ICD codes, see if they change along with them.
Okay, so just back to the judges. Any follow-up questions for Michael before we turn to some audience Q&A? Umit?
Just a quick one out of curiosity. So when I think about this problem, so there is also the, right now in COVID environment, everything is obviously, most of the things are virtual, even when you see your doctor, I know you just call in and you talk and discuss. But assuming we're in kind of a normal times, quote unquote, so there is this telemedicine space, right? So it's more available 24 hours. I know it's not the same thing, but it's close. And it is another venue to kind of compete with the emergency. So I wonder how looking at that phenomena somehow, rather than the premiums, would change the equation that we're looking at, because ultimate goal is, access. And so what are your thoughts on that?
Yeah, so I think telemedicine isn't tracked by the data. But even if it were, I think that's one of those things that qualitative research would do a lot better. Just to see like patient preferences in terms of telemedicine, if they had immediate access to that versus waiting in the ED for 2 hours, 3 hours, and just see which one they prefer. But I think it'd be definitely really interesting to look at whether or not access to telemedicine leads to any changes. I think for the most part, though, patients prefer to see someone in person. And so I think that maybe in the future after COVID, we'll see greater uptake of telemedicine. But I think between the study period of 2010, 2016, it wouldn't have really done much to change ED visits or primary care visits.
All right, thank you very much, Michael. Panelists. So again, we'll take a few